Hello and welcome everybody, and I'm thrilled today to be talking with Philippa, Dr. Philippa Kaye, and some of you may well recognise her from her, I was going to say TV exploits, but that actually sounds probably a bit ominous, doesn't it? But yeah, Philippa's just got a book out. In fact, I think you've had it, it's been out for a little while.
January.
Yep. And I know that you've done loads and loads of books covering wide range of topics, which is incredible, but we're going to concentrate on the M word, which is the title of her book, which is about the menopause, and it covers a lot of the things that we all want to hear about, the obvious, but also not always the obvious. And today we're going to home in on things that aren't always spoken about, but are probably quite topical for today as well. But Philippa, if you'd like to introduce yourself to start off with, that would be really great.
So hi everyone, my name's Dr. Philippa Kaye. I'm a GP, I'm a mum of 3. I have a particular interest in women, children's and sexual health. And alongside my general practice work, I also work in the media. So you might have seen me on the This Morning sofa or various other places. And yes, I write books, one of which is the M word. And I realized the other day, it was a couple of months ago now, a few months ago, when my daughter came in and she said, "Mummy, I've learned a swear word." She's 7. And I said, "Okay, what is it?" Because I generally have a policy of let's explain what that word means. And she said, "It's the S word." So I said, "Well, that means poo." And she said, "Oh, okay." And then she said, "Mummy, what's the M word? What's the swear word, the M word?" And I said, "No, there's no swear word, the M word." She said, "Yes, there is. You wrote a whole book about it." And I was like, I haven't quite got the joke. Like, the reason it's called the M word is because it is the word which sometimes isn't often as spoken as much as it should be. But she thought it was a swear word, but no.
Oh, well, at least it was just those 2 words, isn't it? Those 2 letters. I think you're lucky there. So what I'm keen to do is to dive into, which I think is a question that actually I don't know if I've actually spoken, or you don't hear it around people generally talking about it, the problem, the shortages on HRT. So I'm diving straight in, but I'm somebody who's on HRT, and it is a nightmare to get hold of it or the combination that you want. And so what's going on?
So I would love to say that the HRT shortage is over. It's not. And we had a load of press interest last year, and there was a really serious shortage last year, and the government produced an HRT SAR, and we all thought marvelous. Only the HRT SAR is no longer in post, and it's still difficult to get medication. And there's a lot of reasons, some of which are increased demand. Increased demand is only a good thing. That means that people are coming forward saying, "Help, I'm in trouble," or "Help, I need something to help me with my symptoms," and that they're getting the help that they need. And actually, that's something which I think can be quite forward planned for. You know, we know that there's been an increased awareness campaign, and that there's been an increased awareness for the past couple of years. So it's not like the prescriptions are going to suddenly fall off. So I think that you know, there should be some preparation for that, but I don't think it's only that. And there's lots of medication shortages, not just HRT, and it's thought to be issues with production from countries such as China affected by COVID. There may be issues related to Brexit. There are lots of issues. Nothing is ever sort of one factor only, which has made us sort of tip over. However, what really can't be underestimated here is the impact that has, and the amount of anxiety and stress that it causes when there are lots of people who are using HRT who find that helps them function, that keeps them in work, that keeps their relationships going, that makes them remember and feel like themselves again. And there is a real anxiety about suddenly stopping that. And, you know, and what can I do? And we've heard stories of people not only driving from pharmacy to pharmacy, but sort of almost black marketing, and, you know, shall I share with my friend, and shall I go to Spain and get some, or whatever. Please don't share with your friends, don't share medicines. And also, you know, the fact that you're going somewhere else, to a different country potentially, it might look the same, but it might not be quite the same. You know, and there's lots of issues involved. So I think it might be helpful to do a quick, what can I do? Now, the first is that since the first sort of real problem with getting HRT, the government have put into place some serious shortage protocols, which means that your doctor may only be able to prescribe certain drugs for a certain amount of time, so that we sort of ration them out, and various medicines go on them and off them, depending on the status quo. Your pharmacist may be able to switch you. So instead of you coming back to the doctor saying, I can't get Estradot, and me saying, okay, well, let's try Everil, that your pharmacist should be able to swap you to an equivalent, be that another patch or another gel. But I think it's really helpful for people to know what those equivalencies are. So we can work out for you the equivalent of, let's say, a 50 microgram patch, and there's lots of different ones, is the same as 2 pumps of estrogel. And so we will be able to work out the equivalent in spray, in patch, in gel. So it might not be the exact one that you're on now, but we should be able to find a way. Now, some people will find that they absorb better with one than another, or they say this patch is less sticky for me, or this patch is too sticky for me, this patch is bigger, or this patch is smaller. So I'm not saying this is a long-term solution, but there are equivalents. At the moment, there's a real issue with getting Uterogestan, which is the micronized progesterone, and we can use other forms of progesterone, be that norethisterone, or some women can have a Mirena coil fitted. So we have ways around. You can double up patches of estrogen. We can cut patches of estrogen. So don't just stop and think, I'm out, I'm done, until the supplies come back in. Ask for help, because there are ways around. We shouldn't need to have them. No. Because we should be able to have the medication that we need. But whilst we're in this situation, there are things that we can do.
And I have to say, all of those things sound very familiar to me. And the first time I was told, well, just cut them, I was going, what? What are you talking about? Cut it. And I had sort of funny triangles and all of those things. But for me, what's so interesting is that the pharmacist can the pharmacist actually change the prescription at the point that you hand it in? They can say, well, we could do the equivalent.
Yeah, at the moment, for HRT, yes, they can. And it's taken some time for all pharmacists to be aware of that, but many, as that information sort of trickles down, and I'm not exactly sure if that's going to be in place forever. The other thing to say is that the cost of the prescriptions, and this has been another political issue, bearing in mind that some people will be on 3 hormones. They'll be on estrogen, progesterone, and testosterone. They might have vaginal estrogen on top. And unless you're in a combination tablet for oral, for estrogen and progesterone, there's one called Bijuve, or a combined patch, that actually you're paying 2 prescription charges. So because you're having your estrogen in one form and your progesterone in another form. Now, prescriptions are free in some parts of the United Kingdom. They're free in Scotland, for example. But in England, women were paying multiple charges for HRT. And some doctors would prescribe 2 months, and some doctors would prescribe 6 months, but the cost adds up. And there's been a real push by menopause campaigners saying make it free, or if not make it free, at least make it a single charge. And so now from April, that you can apply online or in your pharmacy for a single annual HRT prepayment certificate, which is 2 prescription fees for however much you need. But there's a but to it, and the but's a bit disappointing to me. The but is that it includes estrogen and progesterone, but doesn't include testosterone. And many women will take testosterone, and there is no licensed testosterone in the UK for women. We import Androfen, which you can get privately, but on the NHS you're using much smaller doses of Testagel or Testim, which are licensed for men, but that's not included in the prepayments certificate, which is disappointing. And also for women who are taking non-hormonal prescribable treatment for the menopause, so they don't want to take HRT or they can't take HRT, those medicines aren't included for that reason either. So I understand that there are lots of reasons why we might use an anti-seizure medicine like pregabalin. There are lots of reasons you might use it for anxiety, you might use it for pain, you might use it for epilepsy, you might use it for HRT. But if you're using it for HRT, it's excluded from the prepayment certificate. It's not HRT, but as in if you're using it to treat the menopause. So I think there's definitely more that we can do on that front as well.
Gosh, I mean, it is a bit of a minefield, isn't it? So, everybody's being told, which is great, and educated about going on to HRT and the benefits, and then they go to the doctors, and and it's not easy when you start off, because I know from personal experience and having spoken to so many other people that when you start on your HRT journey, what you might have to start with isn't necessarily going to work for you. So there's this messing around to start with to find what works, and then you've got all the issues with supply and all of those things, and you're probably, and especially if you've got brain fog, that must be a nightmare.
And I think that it's that all of this has a real impact on quality of life when perimenopause and menopause have an impact on quality of life. And it begs the question, if the supply issue was with Viagra, would we be having the same problems?
No. But then I have a theory that if men had to give birth, we wouldn't be giving birth in quite the same way that we do now anyway. So, things change, don't they?
I think that there is a big issue about the gender pain gap and women's pain being taken potentially less seriously than men. That there is less research into women's pain, that women are offered pain relief later. There are certain sort of aspects of women's lives which pain is considered acceptable, period pain. And in some places, even, there's still a very big push culturally not to take pain relief during labour. There are women's health conditions like endometriosis where women have significant pain, a lot of the time, and that has a real burden on their lives, and yet it still takes 8 years on average to diagnose endometriosis. So the gender pain gap is definitely real and is definitely an issue.
Yeah, and I mean, but even you could take that argument even further when you're talking about medication, because we know that most medication is prescribed, or the amount of whatever strength you might have is based on an average male of a certain height and a certain build and all of those things. So what else have we got?
Stacey Sims, who wrote the book, and she said something like, women aren't just little men. It's not just medicines, it's your car seat, the car seat belt, it's the stab vests that the police women are wearing, it's your crash helmet. And I think actually that COVID was a time that really showed that. So for example, what we saw, the difference in rates of men and women, males and females in ICU, but also the difference in the fact that long COVID is more common in females, and long COVID symptoms can be very similar to perimenopausal symptoms. So these female hormones have a role in all kinds of things. And if we think about the perimenopause and menopause and how we can have symptoms of that from the very hair on our head to the skin on our feet, why wouldn't it affect the rest of your body? When we talk about menopause symptoms, we're talking about every single organ system, and so there must be other effects as well. And if you ask people what's the biggest killer of women, they're likely to say something like breast cancer, but actually it's heart disease. But when you say to somebody, what does a heart attack look like, they imagine an overweight middle-aged elderly gentleman clutching his chest, sweating. But women don't present like that necessarily, and that they're more likely to present with extreme fatigue or feeling dizzy or having indigestion, and so we have to do a lot more research. Women have traditionally been excluded from trials because the menstrual cycle makes it more difficult, or we might get pregnant. Well, more difficult, okay, we need to find out anyway.
Gosh, oh my God, I think we've just opened up a can of worms in that conversation. So moving on to another subject, which is this business about, HRT and cancer. And I mean, there's been, obviously, it was a real problem to start with, and hopefully the word is getting out that you can have HRT even if you've had cancer or you're...
Well, it depends on the kind of cancer that you've
Yeah.
had. And I think, so I was 39 when I was diagnosed with cancer, and I had bowel cancer, and bowel cancer is not a hormone dependent cancer. And so the guidance is very different if you've had a hormone dependent cancer or not. And I think that when you talk about the menopause and cancer, we're not just talking about the average age of the menopause being 50, 51, that actually cancer itself can have an impact on when you go through the menopause. So it might be that your ovaries were removed due to treatment. It might be that you had chemotherapy, and that chemotherapy affects the ovaries. It might be that you have radiotherapy. So you might be 20, 30, who knows? And if you go through a surgical menopause, so the ovaries are removed, it's a bit like falling off a cliff. You go from having everything to nothing, well, not everything, but then you go from having high levels of estrogen to no estrogen. And so the symptoms can be very severe and very sudden in onset. And you may need higher doses. If you're going to have HRT, you might need higher doses of HRT. You then also have the difficult situation, rather like anybody who has a premature menopause, that if you have your ovaries, but you've had chemotherapy, it might come back. So on the one hand, you're told, no, you're in the menopause now, and there are potentially going to be fertility issues, and you might need treatment. And on the other hand, you're told, if you don't want to get pregnant, you should still use contraception as well, just in case, because you were 20 when you had your chemo, so they might come back, when you're 25, 30, who knows? And all of that can be very difficult to manage psychologically. And I think that when we talk about cancer, and I say this as someone that's had cancer and had treatment for cancer, that it's quite hard to see what comes next. It's quite hard to see when treatment finishes. It's quite hard to see what your future will look like. But cancer then took something else from you. It took away for me a decade of ovulation. Now, whether or not I had children, wanted more children, had terrible periods, had fine periods, it's irrelevant. It took it from me. The process of sort of grieving or processing that goes with that. Now, the next issue is about whether or not you can have treatment. If you have a non-hormone dependent cancer, so skin cancer, lung cancer, bowel cancer, then you can have HRT. And if you have, let's say that you have your ovaries removed because of your bowel cancer, in that they've had to clear the pelvis, for example, then you can have HRT. If you've had breast cancer, then the guidance is that if all other forms of treatment have been used and not been effective for you, and that you have had the risks and the benefits explained to you, in those exceptional circumstances, it may be still appropriate to consider HRT. But for the majority of women with breast cancer, we would recommend that you would use something else. Now, there is this idea that if you can't have HRT, there's nothing else, but that's not true. So we have both prescribable and non-prescribable things. You can use something called clonidine. You can use types of antidepressants called SSRIs and SNRIs, and you can use anti-seizure medicines like gabapentin and pregabalin. And that does not mean that I think that you're depressed or have epilepsy. That simply means that we use these medicines for lots of different reasons, and that they can be beneficial for people with flushes and sweats and other symptoms of the perimenopause and menopause. The other important area is that even if someone says, no, HRT is not for you, most people can still have vaginal estrogen. And that leads us onto the next topic that we're going to talk about, which is about sex and libido. But vaginal estrogen is a treatment for genitourinary syndrome of the menopause, which includes symptoms like painful, itchy, burning vulva, vagina, pain on penetration, painful sex, recurrent urinary tract infections, urinary urgency, things like that. And because the vaginal estrogen only acts locally in the tissues around the vagina, it doesn't get absorbed into the rest of the body. And so for most people, unless you're having active breast cancer or on a particular form of treatment for breast cancer, for most people, that's fine. And your GP, if may want to just double check with your oncologist and I ask for advice and guidance, but generally for most people that is okay. And you can also remember things that there CBT is in the NICE guidance to treat menopause, and there are lifestyle measures that you can do. So even if someone says no, HRT is not for you, or says I don't think that's appropriate for you, or if you think I don't want it for whatever reason, don't think now I'm not going to go to the doctor because there's nothing else that can be done, because there are things that can be done.
And that's really interesting, because I was just thinking exactly the same thing, is that, you know, if you say to yourself, oh, well, I've had breast cancer, I know it's a no-no, so that's it. And what's so refreshing is you reinforcing there are so many other things, so many other avenues that you can go down that as a normal lay person you just wouldn't know. But would your doctor know? And I mean, I know the doctor should know, but do they know? Or do they have the patience to tell you about all the different things?
Okay, those are two different questions. So one is about education, and the other is about time and time pressures. And the NHS is a very difficult place to work in sometimes, and the pressure on GPs at the moment is really significant. There's quite simply the reason that you struggle to get an appointment with your GP is not because your GP is not working hard, it's because there's not enough of us, and there's not of all of us in primary care and all the different roles. And there are there are vacancies across the board in the NHS in primary care, secondary care, tertiary care, so GPs and hospitals. We as GPs, you could get to be a GP and not have training on the menopause, not have done a job in the hospital which involved working in the menopause. But once you get to sort of GP registrar role, speciality training, you're gonna see it. And I would hope that therefore your trainer would cover it. And we need to be clearer that everybody does get some menopause training in the same way that, you know, that contraception is a GP's bread and butter. And so too should the menopause. What I would advise people is that very few GPs work in single-handed practices anymore. It's not just the one family doctor, and if you don't like them, then that's it. Most of us work in groups now. And I would ask your GP receptionist, who is the person with extra qualifications in women's health? And if she says no, they say no one, then you say, okay, who has the interest in it that maybe even doesn't have the qualifications, like official diplomas, but might have gone away and done their own CPD and their own learning around it? And there will tend to be someone in the practice that does more women's health than not. And if not, or even if, I never have a problem when somebody comes with something they've taken from the newspaper, something they've printed off NICE, a book that they've highlighted or whatever. Because all it shows is that you and I are on the same team, that you want to do something for your health. Well, I want to do something for your health too. Now, if you come to me and you've printed it off and it is from a non-evidence-based website, or what you're looking at really has no evidence for it, and I know that, then I will tell you. And I will say, I'm sorry, we don't have an evidence base to support the use of X, Y, and Z. If I don't know what it is, I will say, let me go away and find out. And that's okay. If you have a GP or a doctor or anyone that says that they know everything about everything all the time, they're probably lying, because no one can know everything about everything all the time. And so for me, when my doctor says, I'm going to go and look that up, that's actually quite reassuring for me, because they're going to go and look up the latest guidance and hopefully come back to me with what the latest piece of research is. So I don't have a problem when that happens. And when people come to me and they've read a book or they've used a symptom tracker, then that means that we're just going to go through that together, and that's okay. If at the end of all of that, someone still says no for a reason that you don't understand, I would say, please, can you explain it to me? And if it's, I don't know about that, and I don't know what to do, and I don't know where to go to get help, which would be unusual because GPs can ask for advice and guidance from lots of different places. You can always ask for a referral to a menopause clinic. I would love there to be more menopause clinics around the country. It's a bit of a lottery about whether or not you can get one, but that option is still there. So I think that there are things that you can do to both empower yourself and help your GP out. Now, for me, I love it when someone comes in with a symptom tracker, be it before they start treatment or during or after. because that saves time in that 10 minutes that I've got, which is really only 8 minutes, which is probably only 6 minutes because I also have to write everything up. You know, and if you come to me and actually you say, here's my list, this is what I've got, all my symptoms are here, I think they're related to the menopause or whatever, then actually that saves a little bit of time. And it also has really helped people think about their symptoms. So if they come in and they say, I've got flushes and sweats, when I then run through a list, they start saying no to some and yes to some. And then you see the sort of the dots being connected and they're going, oh, well, I didn't think that that could be related, or I didn't think that that could be related. And then when if you start them on something and you say, well, when did your joint pain stop? People don't remember because they only remember pain. They don't remember the absence of pain. They don't know when it stopped. But if they're sort of tracking as they went along, oh, every month, over the last 2 weeks, what was better, what was worse, then that can be really useful to us to know what's working for you and what's not.
I think symptom trackers are brilliant, especially if you've got chronic health conditions. I mean, it really is the only way to understand what is going on with yourself, and it helps the doctor so quickly, doesn't it? It really makes it much easier for you.
Yeah.
Moving on swiftly then to the last thing which we did allude to was the concerns that, you know, women feel, you know, about their sex life and how they change. So apart from the fact that you're, you know, for a lot of women, they've had children, they don't feel as attractive as they did, and then they suddenly have they have the problems with, you know, dryness now because the body's changing. It is hard. I think it's very hard for many women to cope with, you know, the physical and the psychological effects. And how do you know, what are the best things to do?
I always bring sex up with my perimenopausal or menopausal patients, and most of the time they then will tell me a symptom, or I will ask about a symptom and they'll say yes, and they'll say, thank you for bringing that up, I never would have brought it up myself. And some of that is because women's health is still really linked to women's roles in society and views about women in society. And until we can separate those two things, actually we're damaging women, it's harmful for women's health. But there has been this idea for a long time that women should lie back and think of England, that sex is for men. And even the definition of sex, I mean, as a definition, that's definitely changing, because this idea of sex being penis and vagina penetrative sex is actually a really old-fashioned patriarchal view that sex is for male pleasure, not female pleasure, or male pleasure and procreation, not female pleasure. So if women's health isn't talked about, getting older isn't talked about, but the one thing that really isn't talked about is getting older and still wanting to have an orgasm. We don't talk about that. So it's complex, and it's complex for those sort of societal reasons, and that might be different based in different cultures and backgrounds, but also because libido is complicated because we are complicated, and there are physical contributors to libido, and there are psychological contributors, and then there are societal and cultural ones. So during the perimenopause and menopause, the falling levels of estrogen and testosterone can affect the libido and make the libido go down. But so too can the fact that if you're depressed or anxious, your libido can go down. And if sex hurts because it's dry and is more difficult to become aroused and to produce lubrication, and orgasm is further and further away, then why would you want to have sex if it hurt? So the next time, you don't really want to have sex. And actually, the next time there may even be an involuntary contraction or spasm of the muscles of the vagina and vaginismus, which is entirely out of your control. It is involuntary, but it makes it hurt even more. And, you know, issues with body confidence and self-esteem, and just being so goddamn exhausted that sex is often the last thing on women's minds. But sex is good for you. Orgasms are good for you, and there are lots of things that we can do about it. So the first thing is to ask for help. Now, it may be that it's not possible to sort of calculate, well, there's 10% of my libido depression and there's 10% related to body confidence. It doesn't matter. We're going to just sort of look at all of those things together. And that's what you have to do. And you have to look at all of those things. So some women will find that their libido increases with estrogen in HRT. Other women will find that it improves once they've had estrogen if they also have some testosterone. Some women will find that it improves when they have vaginal estrogen because it doesn't hurt anymore. Some women find that as the estrogen improves their mood, that their libido picks up, or that it improves their sleep and their libido picks up, or it improves their anxiety, that their libido picks up. Some women find that the vagina actually itself becomes smaller and shorter after the menopause. And if you have vaginismus, that involuntary contraction means that penetration, never mind with a penis or a sex toy, even with a tampon, is really painful. And so using vaginal dilators, which start off really small, really tiny, and working your way up over time, often using an external vibrator at the same time to bring some positive biofeedback to learn to associate penetration with pleasure, not pain, can be helpful. Sex toys themselves can be helpful. They improve blood flow to the area, and they can make a real difference. And we can do all of those things. But if the answer is you don't like your partner, none of that's going to help. Because as I said, libido is complicated and all of those factors play a role together. And so psychosexual counseling has a role and lots of other things. But you never have to put up with painful sex. You never have to put up with vaginal dryness. And you never have to put up with the idea that sexual pleasure is for men only. It's not, and that lie back and think of England thing really needs to go. So I would definitely really recommend that women come forward and that they go and talk to their doctors about it, because as I said, there's lots of stuff that can be done.
And also I think it's a good thing to start talking to your partner as well about the menopause, what the menopause means, because it's so many different things, and then when you start talking about it, then you can possibly move on to the sexual side of it. But I know a lot of women will talk about everything else but not, as you've just said, the sexual side of it, because that they worry about what the male or their partner will think in a derogatory way.
And one of the techniques which some psychosexual counselors use is that they take sex off the table. Because lots of my patients will say, I would like to hold hands, I would like to have a cuddle, I would like some comfort and intimacy, which aren't necessarily sex. But the moment that I put my hand on my partner, sex is on the table. And so actually sometimes taking it away makes it feel safer, and saying, okay, so for this week we're going to hold hands, and for this week we're going to kiss, and for this week we're going to cuddle but not touch any potential erogenous zones, and this week we're going to touch here or whatever, that can be quite helpful. And I think though that women's health is not a gender issue. Women's health and men's health are just health, and that everybody should be aware of the health issues of others, because we all have or had parents, siblings, children, spouses, partners, friends, work colleagues. So it's not just about the menopause that people need to know about. They need to know about endometriosis and heavy periods and subfertility and prostate cancer and all of those things, because we need to look out for each other and be compassionate towards each other. And the only way that we can do that is that if we're educated and empowered.
Absolutely, 100%. Well, that's what we're trying to do now, and hopefully, it's been just great listening to you and talking with you, Philippa, because I just think you've just gone straight to the sort of the crux of the problems. And I have to say, I wish you were my doctor. That would be nice.
We've just got time to say a little anecdote, which I read about when I was writing the first edition of the M Word, and about the reasons behind the menopause and the various hypotheses around it. And I didn't include it in the first book, and I included it in the second because I spoke about it in every interview and I really regretted it. But I think that it's an allegory of how we view the menopause, and it's about a form of aphid. Now, the reason that I got as far as aphids is because I went into the animal world and said, who else goes through a menopause? Elephants don't, really matriarchal society, and it's us and some kind of pilot whale or something. And no one else. Not even our closest genetic, cousins don't. But in the insect world, they don't have periods. It's not quite the same, but their insects some insects have a post-reproductive phase of life. And there is a kind of aphid that when the colony of aphids is under attack from a ladybird, they send out the postmenopausal females to defend the colony. And I think that had a wildlife expert looked at that 50 years ago, they would have said they're sending out the postmenopausal females because they've served their purpose in that colony. So they can go and die defending the colony because it doesn't matter anymore. And now I think we need to change that message to say they are sending out their wisest and their strongest out to defend the colony, and that's what we are, and that we're going to live that third of our lives in a post-reproductive, post-menopausal state, whether or not we had children, whether or not we hated periods. We're going to live that to the best of our ability because now we're at our best.
And all the wisdom that we have accrued, that we can support society even further.
Yeah,
which
absolutely.
I think is essential nowadays in caring for people as people do get older. It's a fact.
Yeah.
So thank you very well. On that note, we'll carry on. And thank you so much for your time. It's been a real pleasure.
Thanks for having me.
Thank you.